Before we get started, does anybody have any questions about NG2 placement? Or any thoughts? I definitely have an aversion to anything GI, personally. All right, so NG2 placement. What do y'all think? Is anybody? A few people's got their sheets, right? And y'all gonna kind of help me along, all right? But of course, with anything that we're doing, what do we have to make sure we have before we get started?
Supplies.
What else? Before we gather our supplies, what do we got to make sure?
The information.
We got to order. We need to know why the patient's getting an NG2, because why do we need to know why they're getting, what the diagnosis or concern is? Why do we need to know that?
So you can explain it?
That's one thing.
To make sure you're using the proper materials?
Yeah, that's because size matters, you know, as far as what tube you're going to use. But,
To know what you're going to be working with.
and you know what to assess, right? That's, you know, if somebody's got a blockage or if they're vomiting, you need to be prepared to go in there with, you know, something to help them with either their, you know, if they do get sick, you know, in order to know what to assess for, okay? Of course, whenever we get started, and this, you know, the good thing, I mean, these sheets are great, you know, and they pretty much follow the book, but, you know, it goes by assessment, then planning, and then implementation, but it doesn't always normally fall in place of how you need to do it. I know y'all realize that. But just thinking about, you know, that is one way to break it down though, because we will be going in, identifying, of course, our patient, pulling for privacy. And at that point, whenever I identify my patient, I'm going to make sure that they understand what's going on and what the purpose is and that they're going to be getting an NG2. Now, as far as we talked in class, you're going to determine what nair you're going to use. Is that correct? Mm-hmm. Okay. And so it talks about using a tissue and having this patient to blow into the tissue. And that's to clear, you know, to clear that airway. But what also is it telling us?
Table. You're going to hit your table.
Ma'am?
You're going to hit your table.
What else is it telling us? Thank you. What else is it telling us? She's so observant. What else is it telling us? People, when you blow your nose, just like say if you blow air out of this side, you blow air out of this side.
You're making sure that you have a good passage.
Because it's going to make more noise if there's a more narrow passage, right? So that's something you'll be assessing for. So having this patient, if you will, you know, they can hold it. You don't have to hold it, you know. Let them blow into that and then maybe even kind of determine which nair would be best. Getting a light. I do not have a flashlight. If somebody has a pen light, you're welcome to give it to me. But looking into the nose, you can literally see polyps, you know, and or cyst in there or growths, and you would not want to go that direction. I have witnessed someone putting in an NG tube, and the patient was conscious, and there was blood everywhere. So I'm going to prepare y'all. This is not always a simple task, okay? And there's normally more than one. You want to have a little help in there, at least one other person, if at all possible, because it's pretty scary for the patient, and that's why it's real important that you explain to them what's going on, okay? But it can be upsetting for them. So now, you know, I've chose which side, and I've chose that I want to go onto this right side. So would I go to that side to put it in? I'm left-handed, so I'm not going to that side to put it in because I'm going to feed this way, not this way. It's going to be awkward for me. You always want to position yourself to where you're going to be able to take the best care of your patient as possible, okay? Whatever that may be. That's why you always need to make sure you got plenty of room to work, okay? Because you don't want to put yourself in an awkward position, either hurt yourself or not be able to do what you're planning to do because you're using the wrong hand. So it's talking about unwrapping and coiling this tube. These tubes are pretty stiff. They've been packaged for what, a year or two? 3? They're telling. It talks about unwrapping it. If it's real stiff or you can't get this tube to, what would I wanna do before I touch this tube though?
Put it in warm water.
Wash my hands. I don't think it's on there, but you do. Because this is gonna go in that body, and so we don't want to, be touching on it if our hands are not clean, okay? This one's pretty,
So it's not sterile?
no ma'am.
So we don't need gloves.
You need gloves.
You don't have gloves on.
But I'm not at the point yet to, it would be okay to put gloves on to do this. When you need gloves on is when you're inserting the tube, when you're gonna be coming in contact with their fluids. Would it be better to have gloves on because I could have things on my hand even though I clean them?
Yes.
It'd probably be better to have them on. You know, anytime I touch something that's, even sometimes when I'm drawing up injections that are gonna go like in certain areas, especially like a joint, something you want to really be clean, I put gloves on to draw that up, even though I wash my hands. So the thing is though, is we gotta think about, is this going into the belly? Is the belly clean?
No.
It's not really considered clean, okay? So if I had a choice, or if I was sitting here doing this to an actual patient, yes, I'd probably already put my gloves on after I wash my hands, but I didn't do that. I'm following this crazy list. Okay. So unwrap, and then if it felt too stiff, I could put it in a basin with warm water. Is that warm water sterile?
No.
Is that basin sterile?
No.
No, so my hands could possibly even be cleaner than what I put it in, but regardless, I would probably put gloves on. So we wanna unwrap it. And then this talks about, it's still talking about the assessment, I wouldn't do my measurements just yet. Next, I wanna make sure that I personally have all my equipment together, okay? That's what I would do. I'd make sure that I have this list of things, the water, the straw. You like your straws? I'll get y'all some straws. Water, straw, a lubricant. I couldn't find any little packets of lubricant, okay? I don't think you guys have them in your pack either, but you would wanna have a lubricant, which is this here. And tissues, which we've already used. Tape to tape what? The tube. Our emesis basin, I did have one and it's gone now. Y'all can pass me one out of them. I put them in each one of those. I just lost it sometime yesterday. Our flashlight, stethoscope. Why do we need our stethoscope?
Make sure it's in the right places.
Right? And gloves. Make sure I haven't missed anything over here. Gotta mark my tube. We wanna always make sure we got suction, okay? Especially for those patients that are what? Or have problems swallowing. We would wanna get their dentures out, anything that's loose in there, cause we don't wanna knock it, with that tube or anything we're doing, knock those loose and then have issues about possibly swallowing. When I explain my procedure, probably when I do this, hey, this is what I'm gonna do, it's gonna, try not to let it get you anxious, but this is one thing you can do is to, whenever if you feel concerned or worried, or if you get anxious, or you having trouble breathing or anything like that, I just want you to raise your hand. Give me a signal to stop, okay? So you wanna make sure you establish that with them, okay? Any questions so far? So I've already, I'm gonna wash my hands. I've got them in the position that I want them in, because I put them in that position when I looked into their nose, okay? And then we're gonna be now getting ready for placing this tube, okay? So we wanna put this here to protect. I wash my hands. I do wanna put my gloves on. And now, at this point, is when I personally want to measure. walk me through measuring. Somebody tell me what to do.
Tip of nose,
Tip of the nose,
ear.
earlobe.
Mhm. Tip of the nose to the earlobe. Where's next?
xiphoid process.
Okay, so I can let go here, right?
Mhm.
I'm gonna hold here, and then I'm gonna feel for my xiphoid process here. Okay, so what do I want to do with the ear though?
Mark it.
Mark it. We don't want to mark our patient though, right? So I'm gonna mark it here, and then I'm gonna mark it here. Okay. Alright. This again is where I want to make sure I don't just put this tube everywhere. I want to try to keep it as clean as I can because sterile is out of the question, right? And then now I'm going to, a lot of times what you'll have is like a 4x4 and maybe like a little lubricating jelly, something like that. They told me because these are really hard to pass, they've always put WD-40 on them. If y'all decide to use that, it needs to be over the trash can like I just did, okay? So you put that little bit, do we want this gunked up on there?
No.
No. We just want it kinda damp, okay? Alright, so now again, I would kinda go through that process of explaining, right? Let them know what we're doing. And then, what is our next step as far as what position they need to be in and how we need to pass this tube? Okay, so we're in our semi-fowlers. What else? They can kind of tilt that neck back a little bit. And then, okay, I'm going to start inserting this tube. Remember, if you have any kind of shortness of breath, or if you start to feel like you need to cough, let me know, okay? So we're going to pass it to where?
To the
The first mark.
First mark, okay? Now what do I want to do?
You can tape it.
Ma'am?
Tape it.
I'm sorry.
Tape it.
Tape it.
No, you
wanna
want to
look in the back of the
you
throat.
want to get some water so they can sip it as you.
What do I want to tape it for?
Use the flashlight.
There you go. So, we pointed that tip backward and downward, okay? So our patient is sitting up, but when we're putting this in, we want to go toward the back, trying to point down some, okay? Now, if we met resistance, what would we do?
Take it out.
Ma'am?
Take it out.
Take it out.
No, we pull back just a little bit.
Anytime
Take
you're
it out and
starting a
reinsert it.
tube, I'm sorry?
I said take it out and reinsert. I'm not talking about taking it all the way out. You want to
Mhm.
bring it back and then you
Yeah.
want to insert it in.
right, so, and that's a good point, because anytime you're starting an IV, you're doing something like this, you want to try to do your best to leave that initial insertion there. Does that make sense? You may need to move that needle around a little bit, or you may need to move this around a little bit, but you don't ever want to retract all the way back. And then you have to reintroduce, and that's just not fun, you know? That sensation of it leaving and then coming back, if you've ever had that done to you, you don't want it done, okay? So, if we're having trouble passing it, you can back off a little bit, but what is the next step what's one of the first steps you can do before you retract back? This is in your steps. I went over it in class, and it's in this right here. Meet resistance, rotate the tube. Okay? So if I was going in and I started meeting some resistance, I would want to, remember, we want to kind of be going down and back, so you rotate this tube. And a lot of times, just rotating it will change that position of that tip, and it'll pass on, okay? That makes sense? Am I blinding you? So rotate the tube. So we've stopped at that first mark. So where should we be at in the body right now?
Right.
Back of the throat. So I want to look back here. On in. Look back here. I don't see it yet. I don't think I will either. No. Possibly. Yeah, I don't see it yet. So we're going to be looking for into the back of the throat. What are we going to be looking for when we look?
See if it's coiled.
Coiling. Making sure it's not shooting right out the mouth. seen that happen before.
Oh.
I hadn't done this, I've seen it being done a lot, but anyway. So, so you're gonna look in the back of the throat, and now what do we want to tell the patient to help advance this tube?
Put it on the
The
swallow.
lower chin.
Sorry?
Swallow.
That's one thing, but
Lower
where,
the chin.
lower the chin. So that puts that anatomical position in better for that tube to be passed on down, okay, you guys? So tilting that head down, okay? And then also you said taking sips, okay? So here's your cup. This gives them something to do. Hold your cup, take little sips of water. Now, as they take a sip of water, what does that do to help us ensure we don't go into the respiratory tract? Ma'am?
Listen for grateful. You can hear
Wait,
what's in
you
it.
said what? You have them swallow it.
So
don't
when
you?
when they're swallowing, what's happening physiologically?
Closes off the airways.
It closes off the airway. It closes. When we drink, what happens? The epiglottis goes what?
No.
Flaps down over that trachea, okay? So when we're passing that tube, that's why we're having them to swallow. We can do things all day long, just like we're told to do. But until you understand why you're doing it, you need that understanding, okay? So when you're doing things, understand why you're doing it and what you're doing it for, because it's just gonna make you be able to do a better job and be more knowledgeable about your processes, okay? So, taking a sip of that water. How far do I advance that tube as they're taking a sip?
3 to 5 minutes.
3 to 5 inches. So, and then of course, what are we watching for from that patient? All right, I want you to take a swallow. Swallow. Y'all know how far 3 to 5 inches is? That's 3. A dollar bill is 6 inches long. Okay? We like dollar bills. So, dollar bills is 6 inches long, okay? So 3 to 5 inches. Normally this is gonna be 3 inches, like each phalange is gonna be like 1, 2, 3 inch, okay? So 3 to 5 inches, okay, take another swallow. What am I looking for?
Your mark.
My other mark. So, take a swallow, okay? What if he raised his hand now, what would I do?
Stop.
What else would I do?
Retract a little.
Nuh-uh, what would I do? Retract what?
Rotate.
And rotate.
No,
No, we tried it all the
we're
way.
choking him. It's going in his lungs, what do we do?
Pull it back.
Pull it out.
Pull it back to the what?
First mark.
First mark, because that's a safe place, right? So we're back to our first mark. Okay. All right, now they're freaking out, okay? Because we have just literally put a tube down into the respiratory tract. So we're gonna try it again though, we gotta get this tube in. So swallow, where's his head? Down. Does it stay down the whole time? Don't have to. Just until we feel like we've made it down in towards this direction. Does that make sense? Alright, so swallow, he's swallowing 3 to 5 inches. Alright, we're not having any problems. That seems like a long way, doesn't it?
Yeah.
Alright, he says he's good. And that's as far as it will go. Okay, now I'm at my mark. Now, what do I do with this tube?
Take it.
Where's my tape? Right here? What do I do with this tube while I get my tape? What's gonna happen if I let go?
He's gonna fall out.
It's probably gonna be pushed out, possibly. So you do wanna have your tape pulled or torn beforehand. This is not ideally the tape to use. Ideally, it's gonna be a lot wider. Or in most hospitals, they're gonna have these little cute things that go over their nose and kind of holds it, okay? So the way to do this is to tear this tape down the middle. So you can do what? Wrap it around the nose. So this is what it would look like, okay? With one piece of tape. You would split your tape, okay? And then what would I do? Wrap it around. You pick one, wrap it around, you pick the other one, wrap it around, okay? So that's there. Do I want to close up the other side?
No.
No. They'll appreciate that. If you don't. we talked about this. Discontinue the procedure. Raise the tube to the first mark if there's signs of distress, such as gasping, coughing, bluish skin color. How quick is there going to turn blue that quick?
No.
Or inability to speak or hum. So when you retract that tube back, what you can do is say, once they kind of calm down, say, okay, I need you to talk to me. I need you to say something. Or hum, whatever you can do. You want to hear those vocal cords working, okay? So that's something to do before you start pushing that tube back through, okay? Now, are we done? Our tube's in. What's the next? What do we need to make sure of? Placement, okay? So how do we check placement? Listening, what am I listening for?
The bowls area not you still.
Ma'am?
The bowls area not you still.
That's right. So, this, never understood why it's there. It's there. This is your, there it is. That's why it's there. I told you I never used one. So this is your cap, right? I told you I never used one of these. This is your cap, okay? So when I instilled this, or when I inserted this rather, I would want to go ahead and cap that, okay? Because what could happen? I was talking to one of the nurses here today, and they said that they were putting these in, one of these in one time, and bowel came up. That means they had an ileus or something, big obstruction. So that's why I say you kind of want to have somebody with you, because it could be quite a mess. So doesn't say really. Let's see. Call to proceeds for the day, but let's see. Yeah, but assess placement by using 2 different methods. It doesn't suggest which method to use first. What would you think putting air in first to listen, and then that's kind of what I would want to do, is to put air in first and then withdraw to see if my residual was in there. Personally, is what I would want to do.
Yeah, I would inject the air.
That's just not, they don't make mention of that, okay? So we're gonna place that tube there. We're listening. Where's my stomach at? Okay, there's a stomach and there's an abdomen. What is that? There's a stomach and there's an abdomen. Where's the stomach? Okay. That's pretty much the entrance of, and then that stomach kind of lays off to the right a little bit, okay? Because we got, our liver kind of comes over the top. And but it's about like right in here, okay? So we don't want to be listening down here. Because what do we want to do when we're listening? We want to go on top of what? Do I listen over the clothes?
No.
Where do I listen?
On the skin.
On the skin. Okay. So our stomach, here's our xiphoid process here. So our stomach, I'd listen about right here. And then I'm going to be listening for that air to bubble. We don't want to put a whole bunch. All right? I hear a bubble. This is how we do this on checkoff. Okay, I hear the air passing in. And then I would want to retract for stomach contents. And then you retract, and then all of a sudden you see it coming, okay? So you know that you're there, okay? So what do you do with those contents? It's in that tube. So I'll check my placement. Personally, I guess it would depend on if they were going to go to suction or tube feeding, if that makes sense. If we're suctioning, I'd kind of just leave it where it was at, hook suction to it, okay? If I was tube feeding, we don't want to leave it though, because, unless it's going to be hooked to suction, because we don't want it clogged up, right? So we're going to do tube feeding, so I'm going to push that back in there, okay? Now I can quickly remove that, place that. So a lot of times you see these taped to the bed up here, right? You do these, right? Well, and a lot of times
We
they're
transport patients that have them. They're normally a lot smaller.
the tube.
Yeah.
Yeah, there's a little bitty, yeah.
Mm-hmm.
Are they normally taped to the bed up here?
Yes.
Okay. Sometimes I didn't know if there was a, so we've assessed the placement. What else can we do to make sure that we have placement?
X-ray.
Okay, what if, cause this tube, it has to be an X-ray detectable tube. I think all these are X-ray detectable at this point, I don't know that, but you gotta have an X-ray detectable tube, because what if you take an X-ray of a tube that's not X-ray detectable?
It's
You
not
may
gonna
see
show.
it.
I see it.
Says if their findings are inconclusive, consult with the physician. A lot of the nurses that I've talked to, they say they don't get x-rays. I think it has to do with the type of tube and the doctor probably who's ordering it. So it says proceed to secure the tube. We've already done that, but then that would be securing it to the bed, okay? We would then properly document but what would we do really before we properly documented? We clean all of our stuff up and wash our hands, use hand sanitizer, right? In here it shows you sample documentation of tube placement. Y'all need to know how to do that, okay? So y'all need to read through this. This was what French was this one? It's a 16, so we wanna put that, and it's on these tubes, you know that you lubricated it, inserted without difficulty, right, left nair. If you had difficulty, what would you put it? Yes. Then what else would you put right behind it? How you rectified that problem, right? Tube was rotated, and then insertion was successful at that point, you know. Then you put how what. You gotta put how you know what.
Then it's there.
But it's there, okay? It was verified by, you know, the aspirating the gastric secretion, the auscultating over the stomach, and then you can say the color, you know, because if it's in the lung and you pull back, sometimes you can get stuff depending on how bad off that patient is. It can either be blood or sputum, or not sputum, or phlegm from the lungs. What else, and it's on this piece of paper, which is, we talked about in class the other day, not very reliable. You can get a pH of those gastric juices, okay, or gastric aspiration, and then you can put that the tube was secured, and then either placed to suction or in preparation for tube feeding. You know, however you want to chart that, okay. And then position the bed elevated at 30 degrees. Which do they have to have their bed at 30 degrees or 45 or supine if they just got an NG tube sitting in there? Doesn't really matter, right? Because nothing's going in right now, okay? Any questions so far? I think we need a break before we start the next one.